Welcome back to another edition of the Hart2Heart Podcast. And my guest today is Dr. Elie Jarrouge. Eli's been a follower of mine on Twitter. I also follow Elie, and he produces a lot of good information out there on metabolic health. I'm really excited to chat with him today. So Elie, welcome to the show.
Thanks for having me, Mike.
Yeah. So like I was just saying, I follow you on Twitter. You're really into like the low carb space, really into metabolic health, getting people off of medications, which is amazing, giving people the power back by, giving them practical advice on diet, exercise, and how to take control over their health and specifically their metabolic health. But before we kind of talk about metabolic health today, can you give the audience a little bit of a background about yourself?
Absolutely. So I was born and raised in Lebanon and moved to the States in 2000. At the time, I always wanted to be a doctor. So I went to undergrad, went to medical school, residency training. So I was more on a traditional track and never thought of anything lifestyle related. And I did training in kidney disease. I did nephrology. I was board certified in nephrology. And then at that time, I didn't like chronic diseases. So I actually moved from chronic stuff to hospital medicine. So I was a hospitalist for 9 years in Houston.
Wow.
And then during that time, you take care of the acute stuff. But early on, when I started my career, I was 35 pounds overweight. I had high blood pressure. My A1C started getting into the pre-diabetes range. I was right at 5.7. Chronic back pain, really didn't feel good. And I gained that weight over, an 8 to 10 year period. And my back was giving out all the time until one day I tried to do something about it that is lifestyle, because there was nothing on x-rays or when I go to therapy. So I did a Whole30 diet, keto, paleo diet, and then I felt really amazing. And that was like a light bulb that went off in my head, 2015, 2016. Then you quit, you kind of get, I wasn't consistent. I didn't know what I was doing. I was just doing it for, desperate to feel better. And then, learned about keto. I was scared of keto initially. What is that? High fat, saturated fat. I was, traditional doctor, prescribing the same thing, eat less, reduce calories, exercise more. And then, fast forward, I did keto, I did carnivore, and I did everything in between. And I felt better and better and better. All my conditions disappeared. And I started helping friends here, and even took my advice to the hospital, to the bedside. And I've had people really transform their health, because a lot of these people, they come, revolving door, in the hospital, they come in and out. So some of them lose weight, improve their diabetes. And I had one lady come off transplant list for liver transplant because her liver was completely inflamed. She was in liver failure from non-alcoholic fatty liver disease. It wasn't scarred at the time. They did a biopsy. It was not scarred. I told her, look, if you want to avoid this path, and that was early on, I was scared to give this advice. So I told her, look, not official advice, but if you quit sugar, fast, get rid of all junk food, eliminate all that stuff, just eat meat and vegetables, you may have a chance to improve it. And fast forward 3 months, I touched base with her husband, and they told me their liver is normal. They're hiking, they're walking, they're living their life. That she lost 40, 50 pounds. She was amazing. And that's the moment. It was more of an inflection point in my career. It's like, I can't just give prescribing medications. Sure, I make people feel better in the hospital, but then they come back if they don't fix it long term. And that's how I started shifting. And then COVID hit, and more confirmed to me that if you're metabolically unhealthy, you die, you end up in the ICU. And people who were not metabolically unhealthy, they did just fine like any other cold. So I saw it, but people were just ignoring it. It's like, oh, you have to deal with it right now. And that's how I started as a side, posting on Twitter, coaching on the side, and slowly decided to quit hospital medicine. It's been 2 years now. And now all I do is, help coach people get back to health.
Unreal. So a few things to unpack there. The first thing I'm going to say is that nearly every doctor that I talk to who's into a low carb lifestyle practices low carb themselves, and at one point did not practice low carb. So it almost seems like every single doctor who's out there, preaching low carb is actually practicing what they're doing in real life, which is amazing. So
that's my experience too with other people. Yeah.
Yeah. So I really do, commend you on that, because certainly there are a lot of physicians out there who, do things and prescribe things that maybe they wouldn't take for themselves. So it's fantastic to have, physicians like yourself out there who are, teaching patients, teaching people the same things that you're actually doing in your own life and the things that you found have actually worked for you, which is incredible.
Exactly.
The other things there that I want to say too is, there's a couple different topics that we could get started on here today, but you did bring up non-alcoholic fatty liver disease, and that maybe that's a little bit of a deep topic to get into first for when we're talking about metabolic health and low carb. But I think it's probably something that not necessarily is ignored, and we will certainly talk about hypertension and diabetes and obesity, but non-alcoholic fatty liver disease is something that I think we should really be talking about at the forefront as well, in addition to cholesterol and the other diseases I just mentioned, because it is on the rise. It's unbelievable. Like, I see kids who are like literally 16 years old now, and they have fatty liver. Like, every time I do a abdominal ultrasound on someone, it almost comes back as fatty liver, like every time. And people think that fatty liver is only associated with alcohol. And obviously alcohol is bad for your liver. If you drink too much alcohol, obviously that can cause cirrhosis. I'm not saying that it doesn't. But the primary cause of, and I don't know the exact stats right now, but if I had to guess, I'd say a lot more people are experiencing non-alcoholic fatty liver disease than people who are experiencing fatty liver from alcohol itself. And so, we know that the liver, fortunately, is a regenerative organ. So, you can, as you were just saying at the beginning of the podcast, you can have damage done to your liver and you can reverse it. So, just coming back to the case that you just described. So this lady, just so people understand, how bad was her liver and how much did it return? And what did she exactly do in the meantime to get her liver to regenerate that well? Because I think there's a lot of people out there with fatty liver that want to know how they can reverse their condition.
Yeah, absolutely. So the hospital I worked on was a major transplant center, liver transplant center. So we get a lot of these advanced liver diseases. They come for liver transplant evaluation, cirrhosis management, all that stuff. So when I got her, I was this hospitalist in charge of her care, morbidly obese. She had diabetes. She had fatty liver for years. But her liver enzymes were in the hundreds and thousands, actually, I think at some point. Her bilirubin was high. When you look at the numbers, you think someone is like really liver failure. To the point she started to get confused. It was called hepatic encephalopathy. So she was confused. She was getting the treatment for that. And they were expediting transplant workup. They wanted to make sure, they wanted to see if she had fibrosis, which is scar in the liver. So the liver is regenerative to a certain extent. Once you reach liver cirrhosis, then it's irreversible for most people. But when they did it, she had severe inflammation, steatohepatitis, but she did not have a lot of liver fibrosis. So knowing that this is treatable, but there's no pill for that, their advice was like, manage, try to lose weight. And I was so frustrated. Like, I knew at the time I was into Lustig, I was listening about sugar and fatty liver and all how bad it is. Even the liver doctors in the conventional setting, they were already kind of aware that sugar is bad. And they even understood that fasting, one of the liver specialists, he believed in fasting also for liver disease. So I kind of had a window and I gave her that advice. They were desperate. And then I remember her AST, ALT was in the thousands. And then when I looked at the numbers again.
And for people who don't know, those are liver enzymes, AST and ALT.
Yes.
Yeah. Go ahead.
Liver enzymes and bilirubin, what makes people look yellow, jaundice. Hers was 14, 15. I remember that. And then when I checked,
I'm just curious too, did you measure her CRP or C-reactive protein for inflammation?
I did not. Well, at the time, I don't remember measuring that.
Okay.
I don't remember measuring that. I remember her white blood cells were elevated, which is, maybe another surrogate of that. But definitely she was really confused. So when I checked her levels again 3 months later, and I didn't order them, I checked with her husband and he told me her bilirubin was down to 3 from 15, and her the liver enzymes were down to a normal range, and they're not even looking at her anymore as a transplant patient, which was
Wow.
amazing. Liver. And they told me, the liver specialists tell me, the non-alcoholic fatty liver disease is now the number one cause of liver failure and transplant. It used to be, I don't know if it's alcohol first or hepatitis infection, hepatitis C or B, but non-alcoholic was already surpassing, and that was three years ago. So it is a big.
That's
epidemic.
crazy to think, because, obesity is on the rise even more and more every year. And I think the exact numbers are something like 70% of Americans are overweight, and like 42.5% of people are obese. So literally like half the people or more are at risk of getting this condition.
Absolutely.
And it's insane how it's completely reversible. So for this lady, for her to have brought her enzymes down that much, from a sky high level to normal, and then also from going to be a patient who is potentially going to be a transplant patient to a patient who is not going to be a transplant patient, what did she actually do in those 3 months? Like, was it just that she cleaned up her diet and ate low carb, or what exactly? Did she take any supplements? Like, I'm thinking about NAC, I'm thinking about TUDCA, and there's one called Liv52 that seems to also decrease liver enzymes. So did she just use lifestyle? Did she use supplements, or how did she do it?
Yeah, although I didn't coach her myself, so I don't know if she ended up taking supplements, but I know for sure they just cut out, she was big on sugar. So she cut out sugar. I told her specifically about fructose, so high fructose corn syrup, all the liquid sugars, got rid of that. She started fasting. So majority of it was just simply eliminating the ultra processed food, but mainly sugar and refined carbohydrates, and adding intermittent fasting. That was a big tool for her.
So two of the biggest tools that she did to reduce liver enzymes were intermittent fasting, and then also the changes in her diet, which were dramatic, which seemed to be reducing processed foods, reducing carbohydrates. And I imagine that, considering this person was in the condition she was in, she was probably had gone more or less from one extreme to the other. So I imagine she was kind of just eating whatever she wanted, and crazy amounts of carbs, not counting anything, eating sugar, eating whatever she wanted, to going to perhaps maybe not counting calories, but counting carbohydrates, or having some kind of rough estimate, and then also making sure that our carbohydrates are reduced. Is that pretty accurate?
Yeah, that's pretty accurate. I mean, when people are so sick, even just if you don't really just become more mindful of the food and you just avoid food groups, you find improvement. So maybe she took it to the extreme and then really got into it deeply. But all I know is she did it. She didn't go crazy. She just ate real food, but just stopped eating crap, technically. And that helped her. And I'm sure she reversed her diabetes or improved her pre-diabetes. I mean, she lost 40, 50 pounds at the time. I didn't stay in touch, so I don't know what happened after that. But I know that was a moment where it's like, I know food can fix things, especially for this disease. There's no pill for that. You're just another liver. So you have to wait for someone to die to get their liver. And then if you don't change your diet, that liver, I've seen second livers being fatty liver again. And it's just crazy that we don't focus on nutrition as much.
I agree. And in terms of, metabolic health, like a lot of people too, I think, are confused about what tests they should order. And so, there's a lot of confusion over, triglyceride to the HDL ratio, your LDL-C, whether that's important. CRP has been shown to be important. Then we have, you can get an oxidized LDL. You can also get something called in Canada called an NMR test, which measures particle size as well. So, and then there's ApoB, which, Peter Attia has really popularized over the last year or two. So, when you're looking at metabolic health, and maybe I'll just limit the first question just to lipids, because that seems to be the most controversial, nuanced sort of area. What are the primary biomarkers that you're looking at when you're looking at someone's lipids?
Very controversial. It's, ironically, lipid profile for me personally is the least important metric of looking at metabolic health. I mean, except, triglycerides. Triglyceride is pretty sensitive. So my most helpful numbers are triglycerides and HDL.
Okay, but that would be included in the metabolic panel, though, just so people are
yes. Lipid panel.
If you do a lipid panel, you will get triglyceride, HDL, and LDL, which allows you to calculate your triglyceride to HDL ratio.
Right.
But sorry, go ahead.
Yeah. So generally the normal is under 150, but I like to aim for triglyceride under 100 for really optimal health. HDL over 40 for men, over 50 for women. But generally, the higher, the better. And LDL is really, I'm at a point where LDL cholesterol is a number that it's there, but I don't give it. It doesn't tell me anything about your health. You can break it down. Sure, if people want to do NMR, ox LDL, ApoB, it gives you more information. But at the end of the day, it's the non-lipid related markers that I pay attention to. ApoB, for a while, I was starting to kind of buy into the hype. But then when you read about ApoB, every LDL particle has an ApoB attached to it. So when LDL is elevated, ApoB generally tends to go hand in hand with it. So then I was like, if I don't look at LDL and I'm looking at ApoB, I'm still looking at LDL indirectly. So personally, I started to shift also on the LDL side. I look at the pattern particles size. There's pattern A and pattern B, which is the large, buoyant, neutral LDL. And there is a small, dense LDL, and there's oxidized LDL. Controversial.
So do you order then NMR tests?
Not as much anymore. So as I was saying, that I start to focus more on non-lipid related profile. For example, I care more about your waist circumference rather than your LDL. I care more about your fasting insulin level. I care about your glucose, A1C. I really like to look at CRP, particularly the high sensitivity CRP, the HS-CRP. I look even at uric acid,
I've seen one study anyway that showed that high sensitivity CRP is actually a better indicator for cardiovascular health than LDL-C. So, again, I'm not saying that's just one study. I'm not saying it's, definitely true, but there does seem to be, a lot of correlation there. And then, I'll get back into lipids for a sec, but just want to make the comment, like, I know there was a study done fairly recently, Sean Baker had talked about it. And essentially there was healthy people who had sky high LDLs, and then they did a coronary angiogram. I'm not sure how long the follow-up was, 1 year, 2 years or something like that. And from my understanding, there was no real difference in the group that had the high LDL, but were still healthy basically in virtually every other parameter. So they didn't develop atherosclerosis.
Yeah, that's a high, very high. They're on low carb, ketogenic, lean mass hyperresponders, what they looked at. And that study is continuing.
And essentially they were healthy people, like their blood pressure was well controlled, their waist circumference was in an adequate range. Everything was good except this high LDL. So now some people are saying, okay, so this proves that, LDL has, no impact on cardiovascular disease. But there's a lot of people out there, say like Lane Norton, Peter Attia. There's a lot of people who, still believe in LDL-C because of these Mendelian randomization trials where they said that they've seen that lower LDL, still does prove to better outcomes overall. So do you think that it would still be best to lower your LDL even if you have everything else under control? Or are you at the point now where you think that if everything else is under control and LDL is high, then you'd be okay?
It's nuanced. The more recent one also, we found out too that the leaner you get, the higher the LDL. So there seems to be a direct correlation, and I've seen it in clients. So someone comes more obese and their LDL is actually pretty good, and they lose some weight and their LDL may go down or stays the same. But when they get lean, the LDL shoots up. I know it happened with me. My LDL used to be like 120, 130 when I first started. I was actually the least healthy. And then when I got really lean, all metabolic aspect is healthy, my LDL shot up to high 200s and 300s. And I keep seeing it, and I do a CAC scan. So basically, I don't want to ignore the LDL because I'm getting people at a certain time of their life. So if they've been unhealthy for 20 years, getting them at a metabolically healthy spot doesn't mean they don't have disease. So if the LDL is high, and I like to look at a CAC scan, a calcium score, just to see, and then I make sure everything else is better. And I tell them, look, it is controversial out there. Conventional doctors are going to tell you the value is high, you need a statin. And I'm telling you that there's still controversial. There's no evidence when you're metabolically healthy, adjusting the LDL is going to make a big difference. At least I don't believe that. So I try to reassure people that it's not a problem if everything else is better. But if they're on a statin, they want to take a statin, I don't interfere. I tell them, look, this is a risk and benefit, and then you can make that decision.
Yeah, I think we're pretty close on that overall, and maybe closer than I thought. I think that we agree on more or less everything outside of the lipids, and even within the lipids. Like, I'm the same way. If I saw that someone was completely healthy, but their LDL was high, I would say to them, like, listen, I think we should do an oxidized LDL test to see what your oxidized LDL is. Maybe do an ApoB, maybe do an NMR as well. And I don't know if I said, so NMR is testing for lipid particle size. And as Dr. Jarrouge was saying earlier, the small, dense lipid particles are much more atherosclerotic, or will cause heart disease a lot faster than, say, the large fluffy type. So it is an important test. So, again, it's a nuanced subject. I know people are looking for like hard answers, and it is something that I think that you should just discuss with your doctor. So what I'm saying, to give you I guess the hard answer is, if everything is perfectly controlled, but your LDL is high, go get a ApoB, go get an NMR, go get an oxidized LDL. Also look at your triglyceride to HDL ratio, which I do want to ask you about just a little bit more. Also get your CRP done, your waist circumference, like you said. All these things, factor into it. So, the obsession with just lowering the LDL and thinking that your risk of heart disease is going to be low, I think definitely is a fallacy. But I don't we think we should just completely eliminate looking at LDL yet. But I do think that, there's some people who probably will be less likely to develop atherosclerosis or heart disease if everything else is controlled and their LDL is, high, but maybe their oxidized LDL is a little bit lower. So again, a very, very, nuanced subject. But coming back to the triglyceride to HDL ratio, because I did want to ask you about that. So, a lot of people are putting a lot of emphasis on this right now, and for good reason. I have seen studies that have shown that the triglyceride to HDL ratio is, important, or just as an important predictor as, say, LDL-C. And so can you explain why that ratio is so important and why it's becoming more popular?
So when you have we want a low ratio, I think 2 to 1 or something like that. So the lower the triglyceride, that means you're metabolically healthier, which also tends to be tied with higher HDL. So when you do the ratio, for example, if your triglyceride is 100 and HDL is 50, you have a 2 to 1 ratio. That's a pretty good ratio. Some people can go as close to 1 to 1 ratio. I think when you're
or even reverse it. Like, that was one of the questions I was going to ask you, is that, do you think that a 2 to 1 ratio is actually healthy, or do you think that if you're striving to be optimal, it should be 1 to 1, or even reverse, like 2 to 1 HDL to triglycerides?
I don't know if we have an answer for that. And then remember, those are surrogates. So it doesn't mean like if you artificially bring triglyceride down, you can take a pill and bring the triglyceride down. It doesn't mean you're healthier. So for me, they're a window to metabolic health. So if the ratio is off, then I go back to look, is there insulin resistance? Where is there visceral fat? Is there, evidence? Was there a lab error too? I mean, some people, you need to fast enough time to see the results. So I think that it's just a window to metabolic health. If the ratio is off, it's really about looking, maybe you just need more time on the lower carbohydrate diet. If their insulin is elevated, or you can look at other markers like HOMA-IR, and really see what kind of level of insulin resistance. I've never changed my approach looking at these ratios. Or just kind of it usually confirms something else I know from somewhere else in their blood work or metrics, and then just kind of double down on the approach. And eventually it comes down. I had a guy, 600 triglycerides, 630. I just finished with them. 16 weeks later, brought it down to 103.
How?
Low carb. I mean, he actually went more carnivore. But really, this guy was 366 pounds, 40-year-old, A1C 11.5, is raging diabetes. He came to me motivated, but doesn't want pills. Like, I don't want to take pills, but I want to fix this. I was like, okay, let's do it. Cut out all carbs. And of course, that includes sugar and all that stuff. So he basically ate meat and certain vegetables, but gravitated more towards meat, and then eventually started fasting, dropped 47 pounds. He's still over 300 pounds. So, he's still obese, but his A1C went from 11.5 to 5.8. So he's almost there.
That's insane.
His insulin level, despite 16 weeks of not eating any carbohydrates, still like 25 on the US unit. I think you have a different unit in Canada. But basically, glucose went from 330s to low 100s. Completely normalized, blood pressure normalized, everything normalized, energy through the roof. And that's only 16 weeks in. He's going to continue and then lose the next 100 pounds.
And so when he went super low carb, you said that his triglycerides, plummeted, which is amazing, which would have improved his triglyceride to HDL ratio, which should have improved his insulin resistance, which is fantastic. But were there any biomarkers that, went array? Like, did his LDL-C go sky high? Or were there any biomarkers that, a lot of doctors would kind of throw their hands up at?
So the first lipid panel, so LDL is generally calculated. So you need a triglyceride level under 400 to have a value. So I did not have a computed LDL level on the first one. So all I had is it was a total cholesterol of little over 200. So when you actually look at the total cholesterol, this is how useless it is. It doesn't tell you the whole picture. It looks, actually, his total cholesterol was, let's say, 220. Now it's like 240. So it looks like the total cholesterol got worse, but his triglyceride went from 630 to 103. And HDL was 44. It wasn't bad. We went up to 49. So if you look at the ratio, 600 over, 40, I mean, that's a crazy high ratio. And now he's on a ratio literally 2 to 1. If you think about it. So 103 and 49. LDL is only 153. That goes back into when people are still really have a lot of fat, a lot of obesity. LDL doesn't shift up that much. My guess was maybe a little lower, a little higher. It's probably went sideways. But my guess is as he loses more weight and then gets to the leaner side, his LDL is going to start climbing. And that's just been an observation I keep seeing. And then you also, I don't know if you looked at the Oreo study from Nick Norwitz, but he did this kind of silly experiment, but to prove a point, he's a ketogenic, his LDL generally 300 to 400 range, and he kept that ketogenic diet and ate just Oreo cookies for the point just to add carbohydrates, but he picked an unhealthy version, and his LDL plummeted all the way down to 100.
Yeah, I saw that study, the Oreo study.
Yeah. So he wasn't trying to prove anything except, raise questions like, okay. And David Feldman, who's, been working onto this lipid energy model, he already showed like this called the Feldman Protocol. You can predictably lower your LDL on blood work within 3 days of eating a higher carbohydrate diet because you can shift that energy shuffling and then really artificially bring down your LDL.
So in 3 days you can, so you're saying that if someone has a high LDL and they eat high carb for 3 days, they could potentially reduce their
LDL, right? So I don't know if it's 3 days or 4 days, but he did that. You can look it up, Feldman Protocol. again, it's not science-based, it's more of a self-experimentation. And then a lot of people have corroborated that. They did it on themselves, and let's say if LDL was 200 or 300, they ate carbs, and it kind of came down. I'm yet to do it. I just don't want to start eating a lot of carbs and, not feel great. And that's the other thing. If every marker gets better, you feel amazing, you're losing weight, your diabetes is reversed, your blood pressure is normal, inflammation is gone, the only markers going the other way is LDL. Just common sense tells you can't be that this diet has a vendetta against your heart while everything else gets better. And then you have the number one risk of of heart disease, diabetes, obesity, prediabetes, hypertension, smoking, all these before you get to LDL. So I don't ignore LDL, but I don't prioritize it,
And what about, Chris Palmer has talked a lot about, brain energy and how mental health is part of your metabolic health, or your metabolic health influences your mental health. Is that something that you've seen with your clients and with your patients, Eli, that like once they've gone low carb, or once they've, changed or shifted their diet, they've also shifted their mindset or improved their overall mental health and well-being?
Absolutely. Even before I knew that was the case. So when I first got started, things come in cluster. You see them in practice. They come like overweight. They also have prediabetes, type 2 diabetes. They have high blood pressure. They have acid reflux, a little anxious, a mild depression on SSRI. So you just kind of see these clusters of conditions. And then I've helped people in group or in one-on-one for metabolic health reasons, but all of a sudden their years of anxiety just melts away. Their depression goes away. Their mindset, their outlook at life changes. So, and I've even helped a guy come off Paxil, which is one of the oldest SSRI.
Wow. That is one of the worst ones. Yes. I always tell people Paxil and Effexor, those are the ones that I find my patients have the worst time coming off of. Maybe the Effexor is worse, but like people say that even if they don't take it like at the same time of the day, they'll get these like brain zaps. And like, I'll be honest, I was one of the doctors when people were telling me they're getting brain zaps like 10 to 15 years ago. I was like, I don't know if this person's getting brain zaps. But when people keep telling you it over and over and over again, then, it's thing. And then the other thing with paroxetine or Paxil, it seems like a lot of, I don't know if it's like more in women or maybe, but it seems like a lot of women in my practice who take that, they have a lot of sexual dysfunction with it.
Yeah.
And unfortunately for some people that can be, permanent, which is, part of the reason too, why I'm so into using cannabinoids and also using, psychedelic medicines as well. And I don't know what your thoughts are on that. And we certainly don't have to get into that.
No, it's fine. I'm all for, getting that back into the clinical practice
Yeah, I mean, I think, and I know we won't go into details about the SSRIs, but that is one thing that, we don't really notice sexual dysfunction, with psilocybin and some of these other drugs we do with SSRIs, or selective serotonin, reuptake inhibitors, antidepressants for people who are unaware of what.
But at least psilocybin is more of most often it's just a one-time. I don't know how you're going to do it. It can't be like a one-time thing, and it's just going to access part of your brain that kind of fixes things.
Do you know the mechanism by which, the metabolic health is improving people's mental health? Has that been teased out in the literature at all, or?
Well, Chris Palmer talks about it, and I believe it. It really goes all the way down to the cellular level at the mitochondria. When energy flow and cellular health and inflammation or reactive oxygen species, all these things get more cooled down, the brain starts functioning better. It's just another organ, but I don't know all the pathways. But the brain is complicated. So this guy, by the way, the Paxil, he was on it for 30 years, and then when I was working with him over time, it took us about 8 weeks, but got him off of it. And he did feel weird and realized how numb he was.
8 weeks is pretty good, actually. 8 weeks is, depending on the dose. That's
I think he was he was at 30 milligrams. So, okay. And I'm actually going down by like 5 milligrams every week or two, just kind of, I wasn't sure. It's like, if you feel weird, well, we can hold. but he really was motivated. Now he's been off of it. He feels he has dynamic range of emotions because, he was more blunt emotionally, and now he feels good and he can handle problems. But we went a couple of months on a really low carbohydrate when he started feeling better before we addressed that. Yeah.
That's good to know, though, that, that people need tools when they come off of these medicines. They need to be able to, you can't just come off it and do nothing. You need to be able to come off it and have something to adjust. I use a lot of CBD oil for a lot of patients. I'm not against THC in any way, shape, or form, but I do feel that if you're going to use THC, it's better to use it CBD with it in conjunction, once a month or something. If you want to have, some fun with your friends and just use high THC, I'm not against that either. Like, that's totally cool. But if you're going to use it as like a medicine daily, I would use just CBD only in the day if you can. And then at night, just use a little bit of THC with CBD to kind of help mitigate anxiety or get you to sleep, whatever it is that you're kind of trying to treat.
I don't have a lot of experience with the CBD, but people tell me some of them use those things to help them.
Yeah, it's pretty subtle. Like, I don't think it's like dramatic, but it is pretty subtle, and it does provide benefit for people, and it's particularly in, stressful situations. I think it can be really helpful. Just coming back to the carbs for a second. So, I am someone, like, I've kind of talked about my diet before on this podcast, but essentially I eat like low carb or no carb, like all day. And then right before I work out, I might have 20 or 30 grams of carbs. And then after I work out, I'll have a bunch of berries, and I do have like rice or something afterwards, just because, again, like, I'm 200 pounds. Like, I work out 6 to 7 days a week. Yeah. I use a sauna 5 to 6 to 7 days a week. Some of my workouts are really, really intense, like with the MMA workouts in particular, when we're doing, sparring and drilling and that kind of stuff. So, I've gone like full keto before, where I've done like less than 20 grams of carbs, less than 50 grams of carbs for like literally like 6 months on end or more. Like, I've done that. But for myself, I find myself settling around like 150-ish, maybe even closer to 200, which, sounds like a lot for some people, but given, my size and my activity level, and then also just like my plain genetics, like, I think I'm just a little bit more of, like a hard gainer. Like, I do need to, lift weights pretty hard and eat my 200 grams of protein a day to kind of pack that muscle on. I don't have the Rocks genes.
Yeah.
So, what do you kind of say to, I guess, to some of your clients who are interested in not necessarily bodybuilding, but just kind of keeping extra muscle on their frame? Like, do you let them know that, like, hey, like, it's okay for you to eat carbs, but you got to do it more like within the 2-hour workout of your window? Or what's your sort of approach?
Yeah. So my patients generally tend to be on a really metabolically broken side. So I tell them someone who's metabolically healthy, who's athletic, who's exercised a lot of muscles, it's completely different physiological needs. Like, your muscles take up glucose like that, probably your insulin won't even budge because you're depleting your glycogen stores. So I tell them over time they may be able to handle it. And yeah, some people who go hard on workouts and they feel like they're just running out of steam, we can strategically include some carbohydrates. I don't think carbs in of itself are unhealthy. Just what's the underlying metabolic state. I love rice. I eat rice. I even occasionally eat fruit. And if I go out, I mean, I'm not like dogmatic. Like, unfortunately, some people are getting like very black and white. But in athletics, I think it's a completely different physiologic need. And I even encourage people to work out to increase their muscle mass, to improve their insulin sensitivity when they're not able to completely cut back on carbs. Like, you gotta, stimulate those muscles.
That's a good point. I think we should just talk about that for a point, not to interrupt you there, but like, I think that the more muscle that you have, then the greater you're going to be able to handle your carbs. Am I correct in saying
absolutely,
that?
Absolutely. Yeah.
And why is that? Can you explain?
So if you, I don't know if you know Gabrielle Lyon.
Yeah, I know Gabrielle.
Yeah, she's in Houston now. But yeah, so I like her work. I read her book, but I'm also I've known this. We know muscle is important for health, longevity, mobility, all that stuff. But it is the biggest organ in the body, and muscles is a big thing. I think of it like an ocean for carbon dioxide. You're just kind of a big sink for glucose. When you have a lot of muscle, you can absorb a lot of the glucose, and a lot of the glucose uptake is insulin independent. So if your muscles are going to get their glycogen, their glucose first to replenish their glycogen. So you can absorb a lot of that. I have a lot of like old frail ladies who are thin, they don't have a lot of muscle, and they have type 2 diabetes. So I push those people to start going to the gym, build a few pounds of muscle to be able to, handle that glucose load, because it does decrease your insulin resistance, improve your insulin sensitivity.
So essentially, if you add muscle, if you get jacked in the gym, you can definitely improve your insulin sensitivity, which is going to potentially improve your hemoglobin A1C, and also may improve your insulin resistance, so your triglyceride to HDL ratio. Is that all pretty accurate?
Yeah, I don't know about the triglyceride to HDL ratio because I haven't looked at it, but with a caveat, I still want to say you can't outrun a bad diet or out-exercise a bad diet. So I'm not talking someone who's eating really crappy junk food who's trying to fix it, but definitely everything else equal, having more muscle, you're going to be a little bit better, more metabolically healthy than someone who's not. So if you're eating relatively clean, but you don't want to cut out carbohydrates completely, you're eating clean carbs, working on your muscles can help you, balance that insulin sensitivity and improve your insulin resistance, improve your A1C, improve a lot of aspects of your health.
And so if you were going to coach someone like an athlete, someone who's, needs 150 to 200 grams of carbs a day, would you tell that person to only eat carbs after workouts? And what kind of carbohydrates would you tell that person to eat?
I haven't worked with a lot of athletes, but I will have to go back to what is their underlying metabolic health issue. If they're metabolically healthy, then I'm much more comfortable them probably eat afterward. It depends on how long they exercise and the intensity of it. Like someone who's going to be at the gym for 30 minutes, an hour, you don't need carbs before that because you already have your glycogen stores replenished, assuming you're resting enough between workouts. But it makes sense if someone who doesn't want to affect their insulin resistance and consume carbs for their muscle to do it after an intense workout than before. But it's highly individual. Like you said, you find it better to eat a little bit before and some after. So I think everybody's a little bit individual. You might have more experience than me about that. What do you do?
Yeah, I just find that for myself, if I don't have something before, sometimes I can feel just a little bit depleted, particularly once the workout revs up and gets more intense in the middle of it. And then, like I said, too, like if I don't just, part of it too, with consuming the carbohydrates is also just getting my calories up a little bit. Like if I don't consume enough calories and get enough carbs, I'm just going to lose muscle, which is something that I'm not willing to do at this point. So, when I don't necessarily like coach athletes per se, but if I was going to give someone advice, like to someone like myself who, works out all the time, is fairly lean and, still wants to consume carbohydrates, I think it is individual. Like you said, like potentially they would do better if they, just spread it out throughout the day, perhaps. But for myself, I know what works for me and this is what works for me. And I assume that it's going to work for some other people, but I also assume that it's not going to work for some other people too. So maybe something that we still need to figure out. But yeah. I still think that if you are a athlete, you're eating lots of, and you do want to eat, 150, 200 grams of carbs a day or more, try to eat them probably more around your workout and then try to eat good, clean carbs. And so, that's my next question. So if someone does want to consume 150, 200 grams of protein a day, say they're doing it after or around their workouts, what kind of carbohydrates would you suggest that particular person eat?
The simplest with the least inflammatory aspects. So I think white rice is generally okay, but generally I don't like grains in general for people. For whatever reason, they're very inflammatory, but seems to be white rice is pretty easy. berries, fruit, things like that, but also potatoes. I like potatoes. They seem to do well. Other than that, you start getting into processed junk food. So I think rice and potatoes, you get a lot of carbs. You can get a bunch of carbohydrates from that,
I agree. I think what I've been doing recently is making the rice with bone broth. And add a little bit of protein to it. And that's been really good. So yeah, usually for my carbohydrates, what I do is, like I said, throughout the day, it's almost, nil or nothing. And then before a workout, I may actually have a slice of gluten-free sourdough bread just to give me a little bit of energy. And then after the workout, that's when I have 2 scoops of protein with a bunch of berries in it. I put some sauerkraut in there too, maybe a little bit of vegetable as well. And then when I have my big meal, what I'll do, like for example, last night I had a ton of ground beef. And then with the ground beef, what I've been doing, well, I've been doing this for a long time anyway, but I have been adding guac to it or guacamole, avocado. There's a guy, I forget his name, because I like to give people credit. But anyways, he put a study out recently that showed that when you consume beef with guacamole, you actually have less inflammatory markers like 2-3 hours later. There's less vasoconstriction. So that's kind of interesting. But coming back to the carb part, so I put guac, beef, and then white rice together. And I just find that combination to be perfect. It is delicious, and it's really easy to make too. I'm probably going to post something about this, but literally like 80% of like bodybuilders and like what all they do is they just cook ground beef, ground chicken, ground turkey, ground bison, whatever it is, some kind of meat. And then they have that as their kind of base. And then they have rice, and then they'll add something to it like guac or hot sauce or spices. And like, that's literally what most bodybuilders live off. And they'll just add more carbs. They'll decrease the rice based upon where they're going through in their training cycle, whether they're in season, out of season, whatever. And again, like, I'm not a bodybuilder. I've never done any bodybuilding. I've never coached anyone in bodybuilding. I just know, that seems to be the basis of almost everything. It's just so easy to do. It's so easy to prepare, and you can prepare it for days on end if you freeze the meat.
Absolutely. And it makes sense for bodybuilders. My issue with bodybuilders, a lot of times they apply their physiology, which is very unique, to someone who's morbidly obese, and they think that would work for them. So someone like this guy who had health A1C of 11.5, he was eating rice. He'll be staying in the 400 or 500 glucose, and he'll be a mess. So that's why, a lot of these bodybuilders that sometimes push back on me, or they may, bully me or something, but I tell them it's a different body. But yeah, I agree with you, because you do need insulin to bulk up muscle. So insulin is a growth hormone. It's not just manage glucose. So it makes sense. Your high energy is up from fat and a little bit of carbs. You're getting some insulin stimulus around the time you're going to work out. You're getting the protein for the building blocks. That's how you kind of keep bulking up. But most, I don't know how many people are athletes these days, but definitely.
One thing I wanted to ask you about too, talking about low carbs, saturated fats. So saturated fats is something that, a lot of people have kind of included now more in their diet than they were previously. I feel like saturated fats were demonized. Now people are sort of going the other way, but have we gone too far the other way on it? Like, do you think that there are some dangers to eating too much saturated fats? And do you tell your clients, even though they're going low carb, to kind of stay more on the leaner cuts of meat? Or do you feel like something like saturated fat is something that we don't necessarily need to worry about too much?
I don't think we need to worry about it too much, because you don't find saturated fat in the purest form. Even like red meat, when you look at the composition, it has a mix of saturated, maybe 45, 50%, but the rest of it is monounsaturated. Pork is even more monounsaturated, So I don't worry about it. So butter, all that stuff. I don't think food that we've eaten for thousands of years is all of a sudden making us sick in that sense. Now, if you alter the fat, whether you hydrogenate it, modify it, create trans fats, burn it, heat it, then you can make the fat toxic, possibly. But eating a fatty piece of meat, I don't think it's a problem. And you're already getting a mix of fats. You're not really getting a pure saturated fat. So I don't really worry about it if they're eating a real whole food.
Yeah, I mean, I try to get people to eat more of like the leaner types of meat, and I do strain my fat from ground beef when I use it, just to try and cut down on the saturated fats. I'm certainly not scared of fat by any means. I eat meat every day. I had 4 eggs just before I started this podcast, but I don't kind of go excessive with it. So meaning like, yeah, I'll take the saturated fats that I get from eating the eggs. I'll take the saturated fats that I get from, eating the meat that I eat, but I don't sort of like go overboard with it or think that I can just eat as much saturated fat as I want to. And then the other part of that too is that, you're talking about ground beef, in particular, grass-fed beef. So there's one, as you know, saturated fat, stearic acid. It's an 18 carbon chain fatty acid that has no effect whatsoever on lipids. And so, or a neutral effect as far as we know. And so I know that if a cow is grass fed, then they are going to have a higher stearic acid content than a cow that is non-grass fed. So meaning that, like Eli was saying, if you are going to be consuming beef, most of it, naturally is going to be monounsaturated anyway. And then out of the other, half or 40% of whatever is less that's saturated, if you do get a good cut of beef that's grass fed, most of that or some part of that saturated fat is going to be stearic acid. So you don't need to worry about it too much. So I think that, as long as you have a practical approach, you can still eat lots of meat, you can still eat lots of eggs, and your saturated fat content won't be too sky high, particularly if it's coming from, grass-fed sources. That's sort of how I try.
And to your point, even fat in general, I tell people just don't go above and beyond adding, you don't have to eat a stick of butter and having a whole cup of cream in your coffee. Just eat the fat that is naturally with the food. I mean, the fat that drains out of ground beef, you don't need to drink it. Just eat natural amount of fats and don't go above and beyond. That's what some of my problem with traditional ketogenic, ultra high fat diet. People don't do as well. Some of them, especially women, for some reason, they can't lose weight, or they may feel good GI upset. So I think fat in general, I was
going to say GI upset big time.
Yeah,
all that oil, it's like people just get diarrhea.
Yeah. I don't just focus on protein, lower the carb, eat the fat naturally that comes with it. That turns into a moderate fat approach. And then, to the same point, like saturated fat, you can have that approach as well.
Excellent. So I know we only have 2 or 3 minutes there left. Is there anything else that you wanted to chat about there today? Do you have anything that you're promoting, anything going on? You speaking anywhere soon?
I'm not speaking anywhere soon, but I am active on social media, Twitter and Instagram. My Twitter handle is Elie Jarrouge MD, and my Instagram is Elie_Jarrouge. I try to post food, but also a lot of it is...
You can just spell that for people too?
Yes, Elie, E-L-I-E. Jarrouge is Jarrouge. So I'm on Twitter and Instagram. I'm not big on social media, but I like to post daily a little bit. I motivate people. I try to help them. If they want to work with me or learn more about me, I have a website, metabolichealthmd.com. If they need, I offer a discovery call if they want to talk to me for a little bit. And then if they're interested in my coaching, I can help them as well. So.
Amazing. Well, thank you so much, Eli.
Thank you, Mike.
Shared a lot of good information today. We got through a lot of good topics. We even got through some nitty gritty stuff about biomarkers and blood work, which I think, some people would appreciate. And the non-alcoholic fatty liver disease, that's something I think that we're going to be talking about a lot in the future.
Yes.
Like I said, I see this now, unfortunately, in kids and young adults. Like, it's not something that I'm seeing just in older adults now, just like, we only used to see diabetes, type 2 diabetes, particular in older people. We're seeing that in younger children now. And unfortunately, we're seeing now an alcoholic fatty liver disease. So I really appreciate the work that you're doing there and bringing that to our attention today. Thank you so much for that.
Thank you so much.
And thank you so much, everyone, for listening. And as always, I'll be back again next week.